Without objection, the chair is authorized to declare a recess at any time. Since we are working in a virtual format today, I'd like to go over a few housekeeping items before we proceed. First, if you're experiencing connectivity issues, please make sure you or your staff contact our designated technical support so it can be resolved immediately. Members participating remotely must continue to use the video function for the duration of their participation in the hearing unless they experience connectivity issues or other technical problems that render the member unable to fully participate on camera. It is committee policy that members will remain muted when not recognized, just like turning your microphone on and off during a hearing in person. This is out of courtesy to all members on this committee, and so that background noise does not interfere with another member who is recognized to speak. When you are recognized, you will need to unmute your microphone and pause for a couple of seconds before speaking so that we will be able to hear everything you say. If you wish to be recognized, please raise your hand using the Zoom raise hand function, unmute your microphone, and ask to be recognized. In order to ensure everything members say is captured on the live stream of this hearing, I ask the members to pause for 2 to 3 seconds before beginning to speak. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteranaffairs.hearings@mail.house.gov. It will be uploaded to the committee document repository. Please keep in mind that you will need to refresh the repository page as it does not automatically update. Without objection, members will be recognized in order of seniority for questioning witnesses. This makes it easier for me to make sure all members participating have an opportunity to be recognized. Before we begin, I also would like to ask unanimous consent for our colleague, Representative Womack, to participate in today's hearing. Should he be able to attend? Without objection, so ordered. Does any member have a question about the conduct of this hearing with members participating remotely? Seeing none, I will now recognize myself for an opening statement. Today, the subcommittee will revisit a topic that the committee has previously examined at hearings in 2017, 2019, the culture of patient safety, quality of care, and accountability within VHA medical facilities. Thankfully, the vast majority of veterans receive high-quality health care and more than 100 million encounters with VA clinicians every year. More than 300,000 VA employees deliver world-class care day in and day out, and veterans deserve nothing less than the very best. But we could not ignore instances of serious patient harm that occur in VHA medical facilities, however rare they may be. Over the last several years, several such incidents have grabbed national headlines. Many of us are familiar with what happened at the VA hospital in Clarksburg, West Virginia. A former VA nursing assistant is now serving 7 consecutive life sentences after a thorough criminal investigation led by VA's OIG. She pleaded guilty to 7 counts of second-degree murder and 1 count of assault with intent to commit murder. While working the night shift in an inpatient unit at the VA facility, she injected veterans with insulin they didn't need, which the facility had failed to properly secure, and killed them. In another widely reported case in Fayetteville, Arkansas, a VA pathologist concealed his alcoholism and subverted VA's quality management processes while facility level leaders ignored concerns that had been raised by staff. While employed by VA, the pathologist misdiagnosed more than 3,000 veteran patients, causing serious harm to at least 34. He is now serving 20 years in prison for manslaughter and mail fraud after pleading guilty to these crimes. And just this past summer, in a tragic incident that has not been widely reported in the media, a veteran died by suicide hours after he was discharged from the inpatient mental health unit at the VA hospital in Las Vegas. This veteran had expressed suicidal ideation during his inpatient stay, and he left the facility without an updated suicide safety plan. The general discharge plan the veteran received was unintelligible because the provider that created it had used a dictation service and failed to proofread this document. The OIG found that the facility had failed to properly review the veteran's care or complete the required institutional disclosure to the veteran's next of kin. The National Health Quality Forum calls incidents like these never events. The term never event was coined by Dr. Kenneth Kaiser, who served as VHA's Undersecretary for Health in the late 1990s. He later became the founding president and CEO of the National Quality Forum, one of the premier health quality improvement organizations in the United States. According to the National Quality Forum, it is critical for organizations to review, to report and track adverse events so that stakeholders throughout the healthcare system can learn from them. VHA leaders undertook an enterprise-wide initiative starting in February 2019 to build a high reliability organization. Their goal is to enhance the overall culture of safety and decrease patient harm events at VHA medical facilities nationwide. VHA leaders have been talking the talk, but they have, at least in my opinion, have not been really walking the walk. Unfortunately, the written testimony VHA submitted for this morning's hearing leaves me unconvinced. First, I must say, admonish VA for missing the committee's deadline for submission of testimony, particularly for a hearing on a topic of such importance. Lately, VA submitting testimony on time has become the rare exception, not the rule. I urge the department to do better. We set these deadlines so that members have adequate time to review written statements and prepare for a thoughtful engagement with witnesses. I'll point out that both the OIG and GAO witnesses submitted their written statements well in advance of the deadline, which the subcommittee appreciates. The written testimony we did receive from VA, all of 5 pages, raises many questions about the agency's perception of itself and the observations of external oversight bodies like OIG and GAO. The contrast could not be more stark. On page 2, VA states, quote, when an adverse event occurs, VA facilities conduct a prompt review to understand why the adverse event occurred so that system improvements can be made, unquote. That certainly was not the case in at least 21 of the reports cited in VA's OIG's testimony, which were issued between January 2019 and today. In each of these reports, OIG found that facility leaders failed to promptly and fully review adverse events. The tone of VA's written testimony this morning seems to be one of defensiveness, not an organization that has taken a hard look at itself and embraced the kind of humility and individual accountability it is seeking from its frontline employees. I think that needs to change. Today's hearing will examine at least 4 critical issues. First, VHA leadership gaps. VHA has been without a permanent Undersecretary for Health for almost 5 years. Second, we will discuss the weaknesses of VHA's current oversight structure, which places almost all responsibility for monitoring patient safety and quality of care at the facility level. Oversight and accountability must be a shared responsibility, and VHA needs a permanent leader that will set this tone. Third, I anticipate discussing outdated policies related to patient safety and quality of care. VHA needs to commit itself to more timely reviews and updates of key national policies. Finally, we will examine what progress VHA has made in transforming its culture and improving oversight and accountability since GAO designated veterans healthcare as a high-risk area in 2015. With that agenda before us, I'd like to now recognize Ranking Member Bergman for any opening remarks he may wish to make. I should note that General Bergman was present for each of the 2 previous hearings on this topic, which were held by the Subcommittee on Oversight and Investigations. He probably feels a little like he's having deja vu. So with that, General Bergman, you are recognized.
Thank you, Chairwoman Brownlee. And yeah, it is deja vu. I wish I could say that it was a pleasure to be here today, but that would be far from the truth. The testimony we will
YM. Oh.
Okay, when did I go on mute? All right.
Start out with, it does seem like a deja vu.
So, really, that is God's way of saying, Julia, quite honestly, we need to be back to in-person hearings. Let's get real like the rest of the committees and pass that up your chain. So I'm going to start again. If I go on mute again, I'm pretty good. I used to be able to fly an airplane and talk at the same time, but obviously that's not with the Zoom capabilities. It's past me. So thank you for allowing me to start again after the deja vu. I wish I could say that this was a pleasure to be here today, but that would be far from the truth. The testimony we will hear this morning regarding the quality and the safety of the care provided to veterans in the VA healthcare system is quite frankly damning. The IG will testify today that, quote, leaders across various levels of VHA do not consistently ensure the safety of the veterans they serve, end quote. I have almost no words for the magnitude of that failure. It has, in fact, cost some veterans their lives. Something must change. This hearing is a follow-up to previous hearings held in the Subcommittee on Oversight and Investigation in 2017 and 2019 on this very same subject, patient safety and quality of care. I was the lead Republican on the O&I subcommittee for those hearings, just like I am the lead Republican on the health subcommittee for this hearing. The similarity of the deficiencies described then and now is striking. I have said before that many of VA's problems are the result of lapses in leadership. This is as true today as it ever was. It may be truer, in fact, given that VA is facing a leadership vacuum following the departure of Dr. Stone this past summer. VA announced last week that the department was convening yet another commission to identify Undersecretary of Health candidates. That will be the second such commission this year and the fifth in the last 4 years, according to Military Times. VA claims that this new commission is necessary because so-called irregularities were discovered in the prior commission. That is unacceptable given the life and death consequences, a continued absence of leadership at the top of the largest healthcare system in our country, one still grappling with a global pandemic, can have on veterans and their families. Two things in particular stand out to me when reading the testimony for today's hearing. The first is how critically important it is that veterans be empowered to control their own healthcare choices and decisions within a system like VA's that cannot consistently guarantee their safety and shows a persistent disregard for fixing its own problems. The second is the dire need 4 years after the enactment of the VA Accountability and Whistleblower Protection Act for the VA to fully embrace a culture of accountability. Only then can our bad actors be weeded out and will the hardworking employees be left behind who far outnumber their poor performing colleagues. Only that group then will be able to have confidence in their workplace and in their ability to come forward with concerns or suggestions for how to better serve the veterans in their care, knowing that they will be trusted, respected, and supported. Every VA employee owns a piece of this problem, and every VA employee has an important role to play in solving it, starting with Secretary McDonough and the rest of those at the very top. Something must change. That is the very least that the veterans who rely on the VA healthcare system, the taxpayers who fund it, and the good employees who staff it deserve. And with that, Madam Chairwoman, I yield back.
Thank you, General. I'd now like to introduce our witnesses. First, we welcome Dr. Julie Kroviak. She is the Deputy Assistant Inspector General for Healthcare Inspections at VA's Office of Inspector General. Dr. Kroviak, you have 5 minutes, and we recognize you now.
Chairwoman Brownlee, General Bergman, and subcommittee members, thank you for the opportunity to discuss OIG's oversight of VHA. The OIG's Office of Healthcare Inspections reviews the quality and safety of healthcare provided across VHA, and we report our findings through a variety of publications, such as our hotline and comprehensive healthcare inspections and our national and VISN reviews. We have also recently added reviews of vet centers. These findings lead to recommendations aimed at improving the quality of services and reducing the risks to veterans who entrust their care to VHA. Unfortunately, these reports repeatedly detail that despite employing hundreds of thousands of qualified and dedicated staff, some leaders across multiple levels of VHA do not consistently ensure the safety of the veterans they serve. My written statement provides some recent tragic examples of a nursing assistant who administered insulin to patients to cause their deaths, an impaired pathologist that misread and misdiagnosed specimens that contributed to patient harm and deaths, and a gynecologist that repeatedly used offensive and abusive language during patient encounters. In each of these examples, the unfortunate outcomes could have been minimized or prevented had leaders created and supported an environment that prioritized patient safety. Patient safety is and always will be a shared responsibility among VHA, VISN, and facility leaders, and clinical providers and support staff. Everyone needs to work in coordination to ensure that patients receive high quality and safe care at every interaction. However, these same patients fall victim to unnecessary risk or worse, harm. From our reports, there's a clear underlying theme surrounding these near misses, risks, and sometimes tragedies. There appears to be a broken culture that results from the actions and more often inactions of those leaders. For over a decade, I had the privilege and honor of caring for thousands of veterans as a primary care provider at the DC VA. These women and men entrusted me to provide them high quality care, and that is a sacred trust. To them, I was the VA. Every prescription, every referral, every procedure reflected that trust. Leaders from the most senior and central office to a first-line supervisor on the front line cannot lose sight of the fact that such trust demands that thousands of staff adhere to protocols and procedures that ensure the safety of every patient every time. Only when the culture is laser focused on patient safety, only when the culture makes it safe to report concerns, only when leaders respond and react to those concerns with urgency, and only when leaders hold themselves and their staff accountable for missteps. Only then can VHA truly promise patient safety and earn the trust of veterans and their families. Changes to VHA patient safety are necessary and overdue, but they are impossible without the dedication of strong leaders who recognize that a cultural transformation is required to support meaningful and sustainable change. The OIG supports VHA's High Reliability Organization Initiative, grounded in principles that can reduce risk and improve quality of care when consistently practiced. We also see incredible opportunity for more meaningful interventions and oversight within all levels of VHA to support this transformation. The tremendous size of VHA and its decentralized structure can pose additional challenges to cultural change. As a result, regional and central office leaders need to be more consistent and proactive in their oversight and support of the transformation. In place of repeated reactive VISN and VHA rescue operations, national and regional leaders must assume active oversight roles to support their local teams, particularly their newer leaders and those who direct and oversee lower performing facilities. Standardizing regional governance structures and ensuring clearly defined lines of authority for the most critical operations can help leaders improve safety across the system. Information sharing of best practices as well as process failures is imperative. The responsiveness and tone of VA and VHA's most senior leaders will echo across the system. Sentiments describing patient safety failures as one-offs and the use of defensive or deflective language will undermine the initiatives aimed at accountability, and opportunities to learn and improve will be lost. The stories of 300,000 VHA staff are more often than not stories of how they continue to provide high quality and compassionate care to our veterans. OIG staff and leaders extend our gratitude to all personnel for their participation and cooperation with our oversight activities, even while providing healthcare during a global pandemic. Chairwoman Brownlee, members of the subcommittee, this concludes my statement. I would be happy to answer any questions.
Thank you, Dr. Kroviak, very much. Next is Ms. Sharon Silas. She is a director with the healthcare team at the U.S. Government Accountability Office. Ms. Silas, you have 5 minutes for opening comments.
Chairwoman Brownlee, General Bergman, and members of the subcommittee, thank you for the opportunity to be here today to discuss VA's oversight and accountability of quality healthcare and patient safety issues. My testimony includes information from our body of work on these issues, recommendations we made to address deficiencies, and how these findings and recommendations relate to veterans' healthcare on GAO's high-risk list. As one of the largest healthcare delivery systems in the nation, it is critically important that VA ensure veterans receive quality care, that is healthcare that is safe, effective, patient-centered, timely, efficient, and equitable. VA serves about 9 million veterans, each one deserving of the promise that the VA is making sure their staff and providers are qualified and competent to meet the highest standards in delivering safe, quality healthcare. And when they do not meet these standards, then they are held accountable. In recent years, there have been some high-profile cases of veterans' quality of care and patient safety problems, including VA's failure to ensure that veterans at risk of suicide receive appropriate and timely care, and to prevent unqualified healthcare providers from causing harm to veterans in their care. In addition, GAO, along with the VA OIG, has cited long-standing concerns about VA's oversight of the delivery of quality healthcare and VA's ability to hold its medical centers, providers, and staff accountable for managing risks to patient safety. For example, in 2020, we issued a report that found VA had not taken enough steps to develop a full understanding of the prevalence and nature of suicides taking place on its campuses, including making use of all relevant information it collects about these deaths in order to help prevent future cases of suicide. We have identified persistent weaknesses with VA's management and oversight of its healthcare system, making numerous recommendations to help VA better address oversight and accountability of its healthcare programs and medical centers. For example, in 2019, we reported that VHA's oversight of its regional networks, which are responsible for the day-to-day functions of medical centers' delivery of healthcare, was limited, and that VHA needed to develop a process to better assess network performance, in particular, network's oversight of its medical centers. The number and repetition of recommendations we have made to address deficiencies in oversight and accountability are symptomatic of deeper issues underlying VA's efforts to oversee its delivery of healthcare at medical centers. And actions are needed to not only address our recommendations, but also address the root causes of these deficiencies through broader systemic transformation of the Veterans Health Administration. GAO's high-risk list is a list of agencies and programs that GAO believes to be the most vulnerable to fraud, waste, and abuse or mismanagement, or in need of a broader business transformation. Veterans Healthcare was added to GAO's high-risk list based on numerous criteria, including weaknesses in its oversight that could result in harm to health or safety, or that the risk could result in injury or loss of life. In adding Veterans Healthcare to the high-risk list, GAO identified 5 areas of concern, including inadequate oversight and accountability of its healthcare programs and medical centers. In fact, recommendations addressing oversight and accountability accounted for nearly half of all recommendations since Veterans Healthcare was added to GAO's high-risk list in 2015. In response, VA has been developing an action plan that includes root causes, actions, measures, and milestones, essentially a roadmap for both VA and GAO to monitor progress towards a broader systemic transformation. Specifically, in 2018, VHA identified 2 root causes to its inadequate oversight and accountability of veterans healthcare. First, VHA identified fragmented oversight of its programs and medical centers. And second, VHA identified a culture gap between those delivering care at the medical centers and VHA's central office. GAO has found that these 2 root causes often underlie the deficiencies that we have identified through our audits. VHA has taken specific steps to address the high-risk designation in the area of inadequate oversight and accountability of veterans healthcare, including rolling out its high-reliability organization modernization efforts, reorganizing VHA's central office, and making revisions in the May 2021 high-risk action plan. All are in the early stages, and it will take years to fully implement the transformative changes needed to effectively address root causes. As GAO continues its oversight of VA healthcare programs, it is imperative that VHA continue to build on its efforts that it has begun to transform its ability to oversee medical centers, staff, and providers, and hold them accountable for ensuring quality healthcare and patient safety. Only in making system-wide cultural and structural changes to the oversight of its programs and medical centers will we be able to see fewer deficiencies in delivering veterans healthcare, fewer GAO recommendations, and ultimately see VA fulfill the promise of providing the highest quality healthcare for veterans. This concludes my prepared statement. I'd be happy to answer any questions that you may have.
Thank you, Ms. Stylis, very much. And finally, we have 3 witnesses from the Veterans Health Administration. Ms. Renee Oshensky, VHA's Assistant Undersecretary for Health for Operations, will present the agency's testimony. Ms. Oshensky, I understand you are planning to retire soon after an impressive 42 years of federal service. I am told you are the daughter of a World War II veteran whose service inspired you to spend much of your career serving those who have given so much to our nation. I also hear that you got your start as a federal employee, as an auditor at the GAO. So I know you understand the importance of oversight. After serving as a detailee to the House Appropriations Committee, you moved to Michigan and began your tenure at VA as a budget analyst. After many years of dedicated service and positions of increasing responsibility, you now provide executive direction for more than 1,000 VHA medical facilities nationwide. Thank you for being with us this morning. And in case I don't have another opportunity prior to your retirement, I want to thank you on behalf of the committee for your many years of service and congratulate you on your forthcoming well-deserved retirement. Our nation is greatly appreciative. So thank you very, very much. And you are now Ms. Oshensky is also accompanied this morning by Dr. Gerard Cox, VHA's Assistant Undersecretary for Health for Quality and Patient Safety, and Dr. Teresa Boyd, Network Director from Vision 20, the VA Northwest Health Network. So Ms. Oshensky, you now have 5 minutes for opening comments.
Thank you very much. And good morning, Congresswoman Brownlee, Ranking Member Bergman, and members of the subcommittee. I must say, Congresswoman, you've made an emotional morning even more emotional for me. So I appreciate the opportunity to discuss our oversight to ensure quality and safe care at VHA's medical facilities. As you mentioned, I'm accompanied today by Dr. Gerard Cox and Dr. Teresa Boyd. I want to thank the subcommittee, the GAO, and the OIG for their engagement on this important topic. We at VHA have an ethical and moral obligation to our veterans and their families to ensure safe, high-quality healthcare. There is a motto that sticks with me every day, and that is one bad outcome is too many. And that comes from Dr. Robert Jesse, a former Deputy Undersecretary here, who really began us thinking about how we think about patient safety many years ago. Regrettably, errors do occur. Each mistake is nothing short of a tragedy and represents a failure to meet our commitment to veterans that we serve. We strive to be transparent in disclosing what happened and to express our apologies to the patients and their families. We are deeply saddened when our actions lead to harm to patients, but our feelings, what we and our staff are going through, pale in comparison to what we know the veterans and their families are facing. Patient safety is a driving force in management at the facility and network level. In 2018, VHA began using the Joint Patient Safety Reporting System, commonly known as JPSR. This is a joint application with DoD, which standardizes how we capture and classify medical errors, close calls, and near misses that happen at the medical centers and that are reported by those same frontline employees. Please understand that these events are reviewed every day in leadership meetings at most every medical center across the country. The goal is to gain knowledge about safety-related incidents and prevent any future patient harm by dealing with those issues and raising staff awareness of them. High-risk events identified during these reviews are then reported to the VISN level patient safety officers for further analysis and reporting across facilities. Our VHA Governance Board begins each day of our meeting with a safety story from the field. These are often told by medical center staff, describing situations where frontline employees saw something going wrong. Sometimes they are individual errors, sometimes they are system problems, but they are all issues that we see, fix, and share across the system so that we avoid these errors in the future. Each VISN takes these safety stories back to their networks to spread awareness of these events and how to avoid them. Frontline staff have identified system-wide problems that are then addressed, an example being improving the labeling of some sound-alike, look-alike medications to reduce the risk of misadministration. Additionally, every VISN conducts routine quality reviews of each medical center at least yearly, but may occur more frequently at places that need different levels of oversight. During these visits, the teams are required to assess compliance with OIG recommendations that need to be implemented during the year. Further, VISN chief medical officers are required to do annual reviews of credentialing and privileging audits of practitioners at each of the sites in their networks. We value transparency and are working to change our culture across the system to make sure we report events and prevent future harm. We have talked to you, as you mentioned before, about our high reliability journey. While we have made great progress, many of the sad events that we are talking about today still shows the length that we have to go to achieve where we want to be. And while our environment is supportive of those who report errors and find ways to address them, know that we are also concerned about our accountability and that we do take disciplinary action when there is evidence of neglect and employee misconduct. Before I conclude, I want to address two issues related to the pandemic. The first is the current supply chain. The COVID-19 pandemic exposed global and US supply chain weaknesses, and we expect these disruptions to extend into fiscal year 23. While there's not been much discussion of the challenges that this may have on medical items, please know that VA has been working aggressively to ensure that we have methods to ensure our supply chain resiliency. We're working with the White House and the executive branch agencies to implement the actions of the national strategy for a resilient public health supply chain. And secondly, I feel compelled to take a moment to acknowledge the dedication and sacrifices made by the VHA workforce over the course of the pandemic. There are people who stepped up, more than 5,000 employees who were deployed during DEMPS, more than 200 VHA employees who passed away of COVID-19, the myriad of frontline staff who gave of themselves and put themselves at personal risk each and every day, and the leadership teams who were on site 24/7 during the pandemic. All of them have made great sacrifices. Chairwoman Brownlee, this concludes my opening remarks. My colleagues and I are prepared to answer any questions you may have. Thank you.
Thank you very much for those opening remarks. And, you know, I appreciate your verbal testimony. I have to say I was a little confused at the beginning when reading your written testimony, because you started out in the written testimony on the issues around the supply chain. And I understand that, you know, without supplies, we can't serve our patients the way we need to. So I completely get that, but I was a little caught off guard at the beginning. But I understand its importance, and it sounds like maybe we should, you know, dive into that a little bit more, and maybe have a hearing or something around it to really hear in detail what's taking place. So thank you again for your testimony, and I will now recognize myself for 5 minutes of questions. And so I will start out with the VHA team. You know, there are 3 of you here today. I think that's probably fair to say there are 3 others that might have been able to come to testify today. VHA's Associate Deputy Undersecretary for Risk Management, perhaps, or the Chief Medical Officer, or the Assistant Deputy Undersecretary for Patient Care Services. You know, I think, you know, any and all could have come to testify, but would you agree that these are, you know, everybody that I've mentioned anyway, that these officials have a role, all have a role in patient safety and quality of care? Just yes or no? Do you think that they all do?
Yes, all VA employees have a role.
And so, I guess, you know, my question really is then, you know, where does the sort of proverbial buck stop? You know, who's ultimately responsible for the oversight, the accountability, the patient safety and quality care?
And thank you for that. And I believe one of the things that as we look at our high reliability journey, every employee has a role. When we talk about oversight, I would say every one of those individuals you mentioned has a responsibility to be looking within their particular arenas to ensure that we're doing everything we can regarding patient safety, whether that is dealing with untoward events, as we've talked about here, or whether it's developing tracking systems or oversight of any variety of things that are happening. Every one of those individuals is involved in looking at that.
And I understand that. I think, I mean, I understand that, but I just feel like there's got to be someone or a group of leaders who are really responsible that those things are happening, that, you know, every employee involved in patient care has the responsibility. The buck stops with each and every one of them. And so, you know, that's my sort of my concern. It just doesn't seem to be these clear lines of authority. And I think both OIG and the GAO are both sort of unanimous in saying where they see see some of the issues in terms of a, you know, enterprise-wide oversight and accountability structure. And I know you're talking a lot about this new high reliability organization. And I think, as OIG, I think, said, has a lot of promise. So that's a very positive thing. I do know that since the HRO initiative began in 2019, it started out with 18 sites, 1 in each VISN. It then has been expanded to 72 medical centers, but that means that about half of the medical facilities still are not on board yet. And so if you could address that for a minute. The other issue I wanted to raise around high reliability organizations is that it's my understanding that the guidelines, if you will, on this process is that VHA headquarter level officials are encouraging VA medical centers to conduct daily safety huddles to identify safety risks, et cetera. They're also encouraging facility leaders to hold monthly safety forums and recognize employees that have done something to avoid harm or identity, near misses. So that's also a concern for me, the encourage part as opposed to, a very strong directive. We all know that, each VA medical center operates sort of on their own in many respects, but when it comes to quality of care, patient safety, we want consistency and high quality across the enterprise. So if you could just talk a little bit about those two things. When are all VA medical centers going to be on board? And my concern around the language of encouraging.
Congresswoman Brownlee, I'm going to make a first answer and then I'm going to turn it over to Dr. Cox. What I will say is there is incredible dedication to becoming part of the high reliability organization. And I will tell you that regardless of whether or not somebody is actually enrolled in that program or getting the extra resources, that every facility across the country is implementing pieces of the high reliability framework, because it is something that has resonated with each and every leader and each and every employee. So Jerry, if I could turn to you about, sorry, Dr. Cox, turn to you about the specifics.
Sure, I'd be very happy to. So good morning, Chairwoman Brownlee, General Bergman, members of the subcommittee. It's a pleasure to be here. I particularly like the subtitle of the committee's hearing today, Establishing a Culture of Patient Safety at the Veterans Health Administration. Because as Chairwoman Brownlee emphasized in her opening remarks, Dr. Kroviak did, General Bergman mentioned the importance of culture. And that's what the High Reliability Organization journey is all about. It's a cultural transformation. And we know from facilities outside of VA that have undertaken this that it takes years, 5 years or more, to achieve that kind of transformation. So we are in the early stages. As you pointed out, we began ambitiously in 2019 with 18 facilities. Most healthcare systems would attempt to introduce high reliability principles and methods at maybe one hospital or a few in their large system. And we had such enthusiasm and commitment from each of our network directors that in 2019, they all wanted to be involved. And so 18 facilities is a large number to be trying to do this at one time. And then very rapidly expanded in 2020 and 2021 to 3 additional medical centers in each of the business. That's 54 more. That's for the total of 72 who are formally undertaking this initiative are now. And the answer to your question, Chairwoman, is that now in FY22, we plan to expand the rollout of high reliability training and coaching and assessment to the remaining medical centers. So all 170 or so VA medical centers will be beginning or on the road towards achieving higher reliability this year.
Thank you for that, Dr. Cox. And my time, I am way over my time, and so I now recognize General Bergman.
Okay, we'll start with, can you hear me now?
Yes.
All right. Things happen once, things shouldn't happen twice. Otherwise it's, shame on the person trying to rectify, which is kind of an interesting, hopefully valid segue. This is not the first time we're having this conversation. When you talk about creating a culture, no culture survives without consistent leadership. Even though leadership changes, the people in the leadership roles change. But the culture, if set in place properly, everybody feels invested and empowered. And I know that literally the hundreds of thousands of VA employees are invested. It's always the 1 or 2 bad actors who spoil it. But we have to have the culture so that we can overcome that and make the adjustment. Ms. Oshinsky, congratulations on your 4+ decades of faithful service. Thank you. And for you, the first question, what were the irregularities with respect to the previous commission to identify candidates for the VA Undersecretary for Health position? How did they impact the outcome of that commission? And how is the current Biden administration ensuring that they're not repeated?
One of the things I've learned in my 4+ decades is what is in my pay grade. But, the question that you ask, I think we're really looking at, this is something at a very high level. Within VHA, this is not something that we were involved in. So we are, what I can do is submit this question for the record, if I can, so that we can get back to you. I really have no insight. In VHA, we are not involved in the development of the commission nor its activities. So I apologize for not being able to be responsive.
Good answer in that don't make up something if you don't know. That's a failure of too many politicians, but that's a different subject. The point is, get us the answer as best you can on the timeline, because it helps us as a committee understand. In fact, I had breakfast with Secretary McDonough yesterday, and his opening comment was, he is not going to lead the VA towards continuance of the status quo. He is going to lead the VA forward, which means making change. And I believe he will do that. And we need to get this administration to actually help him execute his plan, because in the end, the veterans benefit and so do the employees. Dr. Kroviak, the IG's testimony claims that, quote, leaders across various levels of VHA do not consistently ensure the safety of the veterans they serve, end quote. Why is there such a leadership deficit in the VA healthcare system, and how do the veterans end up paying the price for that?
Thank you, General Bergman. We do see issues with leadership at various levels across VHA, and a lot of it is due to vacancies and newer leaders. And we very much believe they need more support to carry out the activities that promote that culture of patient safety that we're describing here today.
Okay. And Dr. Kroviak and Ms. Silas, both of your organizations have reported on patient safety problems in the VA healthcare system for years. I'm sure that you're just as frustrated as I am about how persistent these problems seem to be and how the progress has been painfully slow. What do you think is needed from your perspective to finally move the needle, even if only a little bit, in a meaningful way? And what has impeded that from happening?
So I'm happy to take that. It's the missed opportunities that we repeatedly see for various levels to intervene when they see something wrong. And it's leaders supporting the prioritizing of that, speaking up and addressing issues with some level of urgency to either prevent further opportunities of risk and harm, or promote that culture more rigorously than it's ever been promoted before.
Ms. Silas?
I would echo what Dr. Kroviak said. I think that, when we look at why VHA is on the GAO's high risk list, especially in terms of oversight and accountability and looking at it through the lens of patient safety, I do think both the cultural issues are a big problem, but also there's structural issues in terms of oversight and accountability. And a lot of these patient safety issues that come up in the medical centers are handled within the medical centers. And I'm not sure there's enough visibility kind of up within the networks and up to the central office to kind of ensure that not only are the providers being held accountable, but also the directors of the medical facilities.
Thank you. With that, Madam Chairwoman, I yield back.
Thank you, General Bergman. I now recognize Representative Lamb for 5 minutes of questions.
Thank you, Madam Chair. Ms. Silas, could we talk for a moment about long-term care? I was wondering if you could go into a little bit more detail about your recommendation that VA do a thorough kind of retrospective on its infection control and long-term care, and whether you think the current plan by VA is a rigorous enough review to be sure that our veterans who are living in long-term care are adequately protected.
Yeah, we issued a report looking at the community living center's response to COVID-19, the pandemic. And in that review, we highlighted the different actions that the facilities and the community living centers took to respond to the pandemic. I think everybody was in the same boat, as the pandemic was evolving, everybody's response was evolving. And so VA was issuing guidance and additional trainings to how to respond. But one of the things that we found was oversight of the infection prevention and control issues was paused during the first year of the pandemic. And then, so there was no annual inspections going on at the CLCs for that first year. And then as the pandemic evolved, the VA had the community living centers do self-assessments and to do it virtually, since we didn't really want to have people going in and conducting those types of inspections in person. But it did take some time for VA to take a look at those self-assessments from the community living centers. And so we did make a recommendation that they do kind of a look back, lessons learned, and to come up with actions that they can take, hopefully there isn't another pandemic, but in the next time that they're in that situation. And we issued that report in July, and we are currently waiting for feedback on what their response is going to be in terms of taking corrective actions and doing that lessons learned. They have 180 days to do that, and we're about 90 days out since we issued that report. So we'll expect to see something in the next couple of months.
Got it. Thank you. Are you able to assess the experience in my congressional district? Was that I would say the CLC performed better as far as protecting its residents from COVID than, I don't know how to quantify it, but a lot of its civilian counterparts. I mean, virtually all of the problems in nursing homes and similar facilities that we had were these sort of independently, privately owned nursing homes, and the CLC numbers were always below what we were seeing. Is that true nationwide? Do you have any way of evaluating how the VA long-term care system performed in comparison to its civilian counterparts?
Sure. I believe when we took a look at the data, the CLCs were a little bit similar into some of the other nursing homes. I think that there were some facilities, especially some of the state veterans homes, that kind of performed, not as well during the pandemic. But we currently have some ongoing work that's looking even in more detail at the community living centers and the quality of care. And that should have some additional information on some of the data that came out of the pandemic.
Okay, thank you. It looks like I have about a minute 20 remaining. So if the VA would like to address the plan to review the infection controls and or my question about the performance about the CLCs. Like I said, the experience in my congressional district was a pretty good one given the challenges of the pandemic, and I would be complimentary of the way that VA handled it locally where we are. So I think that's important to say. But if you could let us know sort of how you see the plan going forward in terms of inspection, obviously that's going to be really important.
Thanks, Congressman. A couple things that I would say is, number one, we are taking obviously a hard look at what GAO put together. We have some CLCs that have not reopened. And remember, this is during the pandemic. So we are doing a lot of things to turn those around and making sure that those few places that we're looking at do what they need to do. And I would say that we sent probably 1,000 employees out to work in nursing homes across the country to really teach them about infection control. I don't know, Dr. Boyd, if you have an example that you may want to talk about with this.
Well, that I can say, so we don't go over time, that definitely happened in Pennsylvania, particularly with the state veterans homes. And right. I think one of the best things you guys did. I mean, it deserves a lot of credit, and it always doesn't get talked about. So like I said, the experience I saw was mostly positive. So I just hope when you develop the long-term plan that GAO has called for, that it's up to the standards they have raised. And with that, Madam Chairwoman, I yield back.
Thank you, Congressman. I now recognize Representative Radewagen for 5 minutes of questions.
Thank you, Chairwoman Brownlee and Ranking Member General Bergman, for holding this hearing, and thank you to the panel for your testimony. Dr. Krobiak, I share your concern that smaller rural facilities face particular challenges with respect to patient safety and quality. How can we make sure that those facilities are prioritized and receive the attention, support, and resources they need without losing out to larger urban facilities with more patients, staff, and resources?
Thank you. I think the ultimate responsibility has to be defined more fully at the VISN level. I think they can provide incredible support more routinely to these facilities that struggle for a variety of reasons. And you are absolutely correct. Rural facilities tend to face greater challenges as it relates to staffing, which ultimately will impact patient safety. So standardizing governance across the VISN level, I think, would be an important start to making sure that there is some uniformity across all the facilities to get the support they need to support the cultural transformation we're describing.
And Ms. Oshinsky, the IG's testimony today includes a recommendation for VA to appoint centralized, specialized clinical leaders to support medical centers with complex specialty cases, care cases, decisions, and reviews in areas, including many rural areas, where local or regional expertise is unavailable or untimely. What do you think of that recommendation, Ms. Oshinsky?
Thank you, Congresswoman. I think we do need to support those more remote facilities because it can be a challenge. Recruitment is certainly a challenge and something that I think is probably going to come up again during this hearing. One of the things that we're really trying to do to the degree possible is to institute our tele system so that we have specialists who are available at the press of a button to help the individuals at those remote sites deal with things that they might not normally see. So we have people who are on track to be able to assist them when they come up against a reading they may not have seen before, or a lab result, or whatever. So there are a variety of things that we're doing. Dr. Boyd, is there anything that you'd like to describe from your network?
Yes, thank you. And thank you for the question. It's a very important one, especially for VISN 20 and many of my other colleagues, a lot of rurality, right? So a couple of things that we do. Ms. Oshinsky just mentioned the telehealth or the virtual modality. That is a way to, across the miles, be an integrated healthcare system, even within a microsystem like a network or a region, if you will. You bring folks from the level 1 complexities, those providers and their skill sets into this virtual platform, if you will, and actually get on the road and go down to a clinic on a regular basis as well. So we share resources where we can hire, say, a specialist in one locality. Maybe that's excess for that one area. They're of good use and supply and a resource for the rest of the VISN, in this case, the network. So we do share the what I call manna from heaven many times, that we can hire a lot in one place, but we do need to be sharing, and that's part of our journey. I hope that that helps a bit.
Thank you, Madam Chairman. I yield back the balance of my time.
Thank you, Representative Radewagen. I now recognize Congressman Mervan for 5 minutes of questions.
Thank you, Chairwoman Brownie. At this time, I'd like to also thank Ms. Oshinsky for your service and for the 4 decades of commitment and dedication to veterans. With that, Ms. Oshinsky, I understand that the Directive 2008-36 regarding suicide risk flags expired in July 2013 and that VHA has since failed to update it. If suicide prevention is the FHA's top clinical priority, why has VHA failed to issue a new directive regarding the suicide risks? And additionally, what risks does the absence of the directive pose for patient safety?
I'm wondering, Dr. Cox, can you take the issue with the directive?
I really can't say much about the status of the directive because I'm not involved with that. The Office of Mental Health and Suicide Prevention would be responsible. But I can assure you, Congressman, that suicide prevention is a major clinical focus and the major priority for our system. That office and its network of mental health professionals across the entire system work diligently to identify veterans who are at risk and to help steer them towards resources when we know that somebody is at high risk for suicide.
Dr. Cox or Ms. Oshinsky, you had mentioned that it ultimately is another department's responsibility on the directive of 2008 and the failure of updating it. Is there a way that someone could get me an answer specifically from the Department of Responsibility or Jurisdiction on why that is and answer those two questions?
Absolutely.
We can get it to you before the end of this hearing, certainly, if that is okay.
Yes. And secondly,
I've been told it's actually still in effect, but we will verify that.
Thank you very much. Then secondly, Ms. Oshinsky, in a related matter, I'm deeply alarmed by the OIG's recent finding that VA medical centers are sometimes failing to communicate suicide risk flags to vet centers that are providing mental health services to our veterans. What access do vet centers currently have to the VISTA or CPRS? And how do you expect this access to change as the EHRM deploys across the country?
In my visits to readjustment counseling centers across the system, they have a very close relationship with the medical centers for the most part, and can contact and speak with the individuals that either may be providing care or need to provide care to veterans that they see at RCS. I believe they have access to their record if given by the individual, but I will verify that as well. I believe that if we look at RCS as providers, they will get a role in Cerner. And I know how well you know our issues with Cerner. They will be given a role and have access based on what the restrictions are for those individuals.
Okay. And my follow-up question is basically, what is the VHA doing to address the OIG's findings regarding the communication of suicide risk flags to the vet centers? Is that what you will get back to us?
Yes, if I may.
Okay. At this time, Chairwoman Brownlee, I'd like to yield back my time.
Thank you, Congressman Mervan, and I will just say thank you for asking the questions that you did. And Ms. Oshinsky, the secretary was in my district a couple of weeks ago, and we visited our local vet center, and this was one of the issues that they raised, that they did not feel they were getting that information that they felt was necessary for them to have. So I think it's an issue that we really need to make sure we're following through on, and actually the vet centers are getting that information that they need. So thank you for that. Representative Murphy, Dr. Murphy, you are now recognized for 5 minutes of questions.
Thank you, Madam Chairman. I want to thank Chairwoman Brownlee and Ranking Member Bergman for holding this very important hearing on patient safety in VA healthcare facilities. As a practicing physician of 30 years, a lot of time I spent in the VA. The health and well-being of my patients and patients in general is of the utmost concern to me. Additionally, I represent over 89,000 veterans who use the various VA healthcare facilities in and around my district. I also spent 3 years as chief of staff of a 900-bed level 1 trauma center, as well as a 10-hospital system, where we work constantly on patient safety issues. So like all of you, I am very, very concerned about patient safety. All of us know that the physician's Hippocratic Oath is to do no harm. Physicians go through extensive and rigorous training to ensure that to the best of our ability, we do no harm to our patients. Getting into medical school in the United States takes unparalleled work and dedication, beginning honestly as early as middle school. The academic rigor in American medical schools is unmatched in this world. Physicians in this country are without a doubt the highest trained and the finest healthcare providers in the world, and they are the unquestionable leaders of the American healthcare team. If we are truly to take the best care of our patient, especially within the VA system, with the complexity of medicine, we simply must have the most qualified individuals leading that team. It is this team-based, physician-led approach to healthcare modeling that leads our veterans to healthier outcomes. Dr. Kroviak, Ms. Silas, Ms. Oshinkak, pardon me, my name, Ms. Oshinaki, Dr. Cox, and Dr. Boyd, as well as you know, per the VA's website, the Stop the Line program is a VA-wide initiative that powers VHA employees to speak up if they see a risk to patient safety. It is my understanding that this program is one of the VA's most important programs for whistleblowers. We've had this at my institutions for several years, and it's very important that it's not a watchdog environment, but if someone has general concerns or verified concerns about safety, that they are able to report them. And this leads me to a major issue of patient safety within the VA program, and that's the VA's proposal to remove physician oversight from surgical anesthesia care in VA facilities. Let me just say this, as a surgeon of 30 years and literally tens of thousands of cases, this proposal honestly terrifies me. As a surgeon, I am in charge of what happens on one side of the sterile drape, and I do not have the ability to be concerned about what happens on the other side of the sterile drape, where my anesthesiologist keeps the patient still, free from pain, and safe. I've worked clearly with anesthesiologists and nurse anesthetists my entire career. The operating room is run by a surgical and anesthetic team, and the most qualified individual to lead those two teams are the physicians. We deserve to give our patients, especially our veterans, the highest quality care possible, and this can only be done by having the most qualified individuals provide their expertise in the operating room. More than 350 VA anesthesiologists, including 10 from my state of North Carolina, have invoked Stop the Line on a memo related to removing physician anesthesiologists from surgical staffing models in VA facilities. The VA anesthesiologists wrote in part, as anesthesia service chiefs and staff anesthesiologists, patient safety is our highest priority. And we believe that this unnecessarily changes and threatens the safety and high quality care delivered to our veterans. They invoked the Stop the Line in 2020, May of 2020, September 2020, and February of 2021 after Secretary Madonna was confirmed. More than 1/3 of VA's anesthesiologists and signed this on. Mr. Chairman, I would like to enter these documents in for the record.
To Madam Chair, is that who you were directing that to?
Yes, ma'am, I apologize.
Without objection.
All right. For Dr. Kroviak, I'd like to ask you as an inspector investigating this, why it has been 8 months since Secretary Madonna received this whistleblower letter, which raised concerns, but yet has not been responded to. How can patient protections be seriously taken if more than 350 VA physician whistleblower letters are being ignored? Seriously, why are these physicians' concerns not being addressed?
So I take the question with the concern you're addressing it, but we don't have any role in policy related to what you're describing at the OIG. If we were brought forward concerns regarding to quality of care, intraoperative or postoperative, relating to the relationship you're describing, we would actually absolutely review them, but we don't get those concerns or have not as of yet.
All right. Let me just say as a closing statement, the healthcare team is a team. I've had instances where things have gone very badly south on the other side of the drape, and if it were not for an anesthesiologist coming to the rescue, the patient would have died. This is not the best care for our patients, and it's not necessary in the VA system. And I would ask you guys to actively discourage this and answer to the very, very valid concerns of the anesthesiologist. Thank you, Madam Chairwoman, and I would yield back.
Thank you, Dr. Murphy, and Congressman Sablon, you're now recognized for 5 minutes of questions.
Yeah, thank you, Madam Chair and General Berkman for holding this hearing. Madam Chair, I think in your next hearing, subcommittee hearing that you call, I will just join you in your office right across the hall from where I am. Let me ask, welcome to our witnesses, and I do acknowledge that VA has some really good doctors and health providers, and I'm envious because in my district, there are no VA facilities, no VA doctors. So my veterans must go to a fee-based doctor contracted by the VA. So let me ask the VA, our VA witnesses, Dr. Cox or others, how does the VA ensure that the safety of my veteran constituents when they receive care outside of a VA-run facility?
Well, thank you, Congressman. Let me attempt to address your question. It's really about what we call community care, like care that veterans receive not from within the VA system, but from community providers that are under contract. And as you know, that program has grown tremendously just in the last few years. And we now have, in the last couple of years, established relationships with contractors in each region of the country, including yours. Within those contractual agreements, there are requirements that the provider network, the community care network, must meet regarding safety of care and quality of care. And the VA Office of Community Care monitors those requirements very closely. Each of the providers has a clinical quality management committee meeting that we participate in, and that's our opportunity to provide oversight to make sure that they're meeting those standards. And I agree with you that there's opportunity for us to strengthen the quality and safety stipulations in our contracts with community care network providers, and we intend to do that as we enter into the next round of contracts.
All right. Yeah, well, thank you. So again, my next question is, and I think you answered my next question about what VA, but let me get a grasp of this. So how large are the fee-based clinics that the VA presently has? How large is it?
We have a very significant footprint in the community, and much of this is due to the Mission Act, as we have given veterans the opportunity, if the wait times are too long, to be able to go out there. So it is extremely significant.
How many contracts do you have? How many clinics are contract fee-based?
Yeah, I will have to get back to you on the actual number of clinics.
All right, I appreciate it, because, you know, and so again, and I think Dr. Cox answered my question to some extent, but let me go ask now Dr. Kroviak, I hope I get that right, and Ms. Silas, the Inspect IG and the GAO, has either office, either the Inspector General or the government or the GAO ever performed similar reviews of fee-based contracted healthcare clinics throughout the country as you have done for VA clinics, medical centers, and so forth?
So I'll answer that. We have done work on specific care encounters where quality was questioned, and in some cases, those were contracted providers that we were reporting on.
And are those information available that we could?
So these were published reports.
All right.
It was a care encounter, and we'll go wherever the record leads us to whichever providers have participated in the care to understand that patient's healthcare journey in the system and in care that's paid for by the system.
Yeah, doctor. All right. So I hope I'm not impulsing. If you could please share that published report with this delegate's office. Thank you.
Yes, absolutely.
All right. Thank you very much, Madam Chair. Again, no, thank you for this. Is really an important hearing, and this oversight of. We're oversight, the subcommittee's oversight of people who are providing oversight themselves, leads us to a different level. And again, the VA does provide great service for many, but there are still things and matters that they could improve on, and we should be there to help them carry it out. And thank you, everyone, for being here and joining us today and providing us important information. Have a good day. I yield back, Madam Chair.
Thank you, Congressman. And if it makes you feel any better, my veterans in my district receive care from contracted physicians.
Right.
So I think we were, mixing apples and oranges a little bit, because there's contracted physicians that provide healthcare, and then there's the community healthcare system. And so, we got to be clear that we're talking, two different things.
The clinic that provides the veterans that has done so for the past 10, 11 years, I think. Her practice is now solo. She's one doctor. She has her own patients. She has veterans, and good thing that the VA provided her with the LPN. I think, LPN, and that's helping out the veterans. But I'm concerned about the overload. But thank you again. I'm way over my time. I'll bring you something right across the hallway. A food made from home.
You are always a bearer of wonderful gifts, Mr. Sablon, so thank you for that. I now recognize Congresswoman Miller Meeks for 5 minutes of questions.
Thank you so much, Chairwoman Brownlee, and I also want to thank Representative Radewagen for asking about rural VA healthcare. And then I'm also going to say that although I'm a 24-year military veteran, I also am a provider and provide services under Veterans Choice and the Mission Act to veterans. I've had outstanding care and outstanding reviews. So I just want to put in my 2 cents for physicians who are in the community. As I said, I am a veteran who served both as a nurse and a physician in the United States Army for 24 years. Also the former director of the Iowa Department of Public Health, and I understand firsthand the importance of standards of care and quality of care. I am gravely concerned, as Representative Dr. Greg Murphy, over the VA National Standards of Practice Initiative, to the extent that it could result in VA facilities moving away from the team-based model care to a nurse-only model. That could put the health and lives of veterans at risk, and I'm concerned that it's being considered without consultation with stakeholders. In August, I sent a letter urging the VA to uphold the team-based physician-led anesthesia care team model as the national standard of practice for that specialty to ensure the safety of our nation's veterans, especially because many of our veterans are sicker and at higher risk, so they have a higher risk profile. Ms. Oshinsky, the team bed physician-led model anesthesia care, for example, was formalized in 2017 after a process that involved over 200,000 comments by veterans. Does VA plan to seek comments from stakeholders regarding this new policy? And if so, when and how will stakeholder feedback be solicited, and how will it be incorporated into the final product?
Thank you for your interest in this issue. We are at the very beginning stages of looking at, and really the issue is far broader than the CRNAs and the anesthesiologists. It's ensuring that all the licensed professionals that we have work up to the highest level of their license. And so it involves a whole lot of things, a whole lot of areas besides anesthesiology. What I can tell you is that we are in the formulative stages of putting together groups for each one of these different areas, which will involve comments from those who are interested in the community, from veterans, but also making sure that legislatively we are doing everything that we need to do. So that is, again, at its very beginning stages. We are putting the policies together and know that this is so that we can stretch our employees to make sure that we can deliver the most care to veterans. This gets us better access if we can make sure that everyone is working to the top of their license. But I certainly hear everything that you're saying.
If I may, yes. In a federal system, the top of a license has different things. So in a state level, people may be limited. The top of their license may not be the same thing as another state's top of the license. So your standards have to take into consideration that as well. I do have another question I'd like to ask while I have time, Ms. Oshinsky. If you can elaborate on the impact of the global supply chain disruptions, how they're having an impact on the VA healthcare system, and steps that the VA is taking to mitigate that impact. For me, the supply chain is a tremendous issue. It's disconcerting to hear this administration say there's very little that they can do about that, where I already have some suggestions and solutions that we can help with some of the supply chain issues that we have now, as we're seeing out of the Port of Los Angeles. So can you tell me the impact they have on VA healthcare, and are there things that you're doing to help mitigate that?
Yes, one of the things, thank you, Congresswoman, one of the things that we try and do is that in our Health Operations Center, we have dedicated 1 day a week to look at what are things that people are finding that we are getting shortages. So we hear from around the country, each of the network leaders talking to us about where there may be issues that they're facing with delays in deliveries. What we do then is try to reassess and move supplies around our system so that we are taking care of anybody who's coming up in short supply. Recently, some of the issues that have come up regard tubes. And we need to move it. As a provider, you probably know those things. So that's one of the things that we do. We may move something from Dr. Boyd's vision to Dr. Bergman's vision because we have a variation in what availability we have. So that's the main thing. And I'm talking mainly from an operational perspective right now.
Thank you so much. I thank all the panelists for their presentations and testimony. And thank you, Chairwoman Brownlee and Representative Bergman. I yield back my time.
Thank you, Congresswoman Miller-Meeks, for that. And I am really glad to hear around the Federal Supremacy Project that you're in the beginning stages and that you will have an open comment period. I've heard concerns from others that the process may not be an open one. So I'm glad to hear that, and I'll hold you to it.
And I believe it's in the Federal Register right now. So just a FYI.
Terrific, thank you. I now recognize Congresswoman Underwood for 5 minutes.
Well, thank you, Madam Chair. As a registered nurse, I'm dedicated to ensuring that veterans have access to the highest quality healthcare in the world. And just to carry the thread from Ms. Miller-Meeks' line of questioning, Ms. Oshinsky, thank you for affirming the VA's position that our advanced practice nurses can practice to the highest level of their education and training. And, we did send a letter to the Secretary about the treatment of the CRNAs, and we're looking forward to his response. But on some important measures, VA is succeeding. In a 2019 Veterans of Foreign Wars report found that more than 4 in 5 surveyed veterans were satisfied with their VA healthcare experiences. But today's hearing is an important reminder that VA still fails far too many of our veterans, and the consequences can be deadly. To promote patient safety, VA needs to fully and swiftly address the ongoing oversight and accountability concerns raised by the VA Inspector General and the Government Accountability Office. And as Ms. Silas stated in her testimony, a culture of accountability requires sustained leadership attention as well as leadership stability. However, as Ms. Silas further noted, the Undersecretary for Health position responsible for managing VA healthcare has not had permanent leadership since January of 2017. Ms. Silas, can you explain how the ongoing lack of permanent leadership at VHA is hindering VA's ability to address oversight and accountability concerns that are impacting quality of care and patient safety?
Sure, thank you for that question. I think you see it in 2 ways. And one, in terms of the high risk efforts, having permanent leadership in the Undersecretary of Health position is incredibly important in setting the tone and expectations for pushing out, developing the action plan, and then also kind of getting the action plan implemented to address high risk. And again, this is the vehicle that will help VA address those root causes that are underlying all of the recommendations and findings that we have that are related to oversight and accountability. I think that one of the things that we saw also with addressing high-risk issues with oversight and accountability is that for that specific area of concern in the action plan, the last issuance of the high-risk plan, our high-risk report last year, we saw a regression in meeting the criteria to be taken off the high-risk list for the area of concern of oversight and accountability. And for all 5 criteria, the oversight and accountability area was rated as unmet. And in talking and working with VA, a lot of that had to do with the change in leadership around those work groups. And so basically it was like a reset as of last spring. Since then, though, we know that the action plan has been revised. They submitted it to Congress in the summer, and there's definitely seems to be some leadership in place for that particular area that has laid the groundwork to go further with their action plan for that area.
Thank you. VA's top clinical priority is preventing suicide among veterans, and one critical step is expanding the department's training on lethal means safety, which is an evidence-based practice to reduce suicide risk by voluntarily limiting access to firearms or other objects that can be used to inflict self-directed violence. Given the proven effectiveness of lethal means safety, VA requires all VHA clinical healthcare providers to take the department's training. However, the training course remains optional for other staff within VA, as well as contractors and community providers. During a March hearing, Secretary McDonough committed to me that he would look for opportunities to further expand this training requirement throughout the enterprise, including to contractors and community providers. VHA has been working to expand the training requirement, but action will be required at the secretary level to ensure VA mandates the training for all VA staff who regularly interact with veterans in their work. Ms. Oshinsky, following up on the secretary's commitment from 7 months ago, can you provide a specific timeline of when and how VA plans to expand the lethal means safety training requirement beyond VHA clinical healthcare providers?
Congressman Underwood, I will need to provide that for the record.
Okay, I just have to tell you, we've been, pretty disappointed. We had a level of candor, I would say, even with the Trump administration on this evidence-based intervention to address the VA's continued #1 clinical priority. I think that the level of hedging and uncertainty that we see among a training requirement for VA clinical staff and the larger staff and contractor and community provider population is a little bit disheartening. And we hope that VHA, Ms. Oshinsky, if you could please take this back to your colleagues, that we are expecting a prompt response, both to this question for the record and our correspondence to the Secretary, so that we can resolve this issue and move forward and make sure that we're protecting all of our veterans. Thank you so much. I yield back.
Thank you, Congresswoman. For that, I now recognize Congressman Allred for 5 minutes of questions. Is Congressman Allred with us? I saw him earlier. I will go to Congressman Womack. So welcome to our hearing. We welcome you, and you have recognized for 5 minutes of questions.
Thank you, Chairwoman Brownlee, excuse me, Ranking Member General Bergman, members of the committee, for the opportunity to speak, and particularly for an outsider off the committee to come into this hearing this morning. It's pretty important information. For those of you unaware, there was an extremely dangerous and deadly situation at my hometown VA. Our chief of pathology, a medical doctor who took an oath to do no harm, reported to work intoxicated, later suspended, then allowed to attend a 3-month inpatient substance abuse treatment program. Following completion of the program, he returned to work at the Fayetteville, Arkansas VA and returned to his supervisory position. He remained in that position for 17 months until he was arrested for a DUI while under the influence of a drug called 2M2B, a powerful drug that mimics the sensation of alcohol but cannot be detected by standard drug screenings. He's been directly linked to 3 veteran deaths, and a review found of his misdiagnoses to be responsible for another 30 serious medical errors, 592 errors that could have risked the patient's health, and more than 3,000 total errors. This necessary review lasted 1.5 years, looked at nearly 34,000 cases dating back to 2005. It required a team of 53 pathologists and cost the taxpayers over $2 million to complete. He is currently in federal prison, thankfully, where he belongs. Ever since, I've been advocating for reforms to ensure this never happens again. Ms. Oshinsky, in your written testimony, you acknowledged changes needed to be made following the tragedy at the VA health system of the Ozarks. I'm encouraged by some of the changes you say the VHA has implemented following the Inspector General's report. However, I believe there is one vital reform missing. In my opinion, one of the main cases of the tragedy at Fayetteville was that Mr. Levy was returned to his supervisory position. While you say the VHA has implemented a policy requiring facilities with 2 or fewer providers in any given specialty to have provider reviews performed at an alternate VA facility, I believe that would not be enough to ensure independent oversight in certain cases. For example, what if a formerly impaired supervisor returned to duty in charge of a section with, say, 3 providers, including him or herself? That supervisor would have immense power to influence or change the reviews performed by their subordinates. I'd like for the VHA to commit to prohibiting health centers from returning a provider found to be intoxicated or impaired on duty to a supervisory position. And so my question is simple. Can you commit to that?
One of the, Congressman, I just have to start out by saying the situation at Fayetteville is probably, I would rank it as one of the darkest days of our VHA history. And we have a long VHA history. So there are so many things about what happened then that we really need to change. And I think we have put a lot of those things in place, and we're still working on them. One of the things that we talked about was how do we routinely test for alcohol use? And it may be something that we need to come back to the Hill to get some help, because right now, alcohol abuse is classified as a disability. And so we have to be somewhat careful about how we approach that. So I would just say we may be coming back to you for help to get some of these things to happen. Another thing that we're doing that would somewhat address what you're saying is that we are going beyond the OIG recommendation about looking at 2 deep providers and having to do that outside. We are expanding by the end of fiscal year 22 that every supervisor will have their work reviewed by someone from outside that chain of command. So we are going far beyond what the initial recommendation was to ensure that we don't get into the position that you're talking about. I will take back what you have said and see what we can discuss with HR about our ability to do exactly what you're asking.
Yeah, thank you so much for your response and for your commitment to evaluating these kinds of concerns. And Chairwoman Brownlee, thank you so much for the opportunity to crash your committee meeting here this morning. General Bergman, thank you so much. And we just appreciate what you guys do. And I know it's not, that what happened in Fayetteville is not across the spectrum of the VA, but certainly if it can happen there, it can happen anywhere. Thank you so much, and yield back the balance of my time.
Yeah, thank you, Congressman, and thank you for joining us today. And I assure you that the subcommittee and the full committee of the VA is well aware of what happened in Fayetteville, and we promise you and commit to you that we will stay on it until we see some policy changes that I'm delighted that Ms. Oshinsky has already proposed. It moves forward. So thank you for being here.
Thank you so much.
So I think most members have left us, but I'd like to go. I have another question or two that I would like to ask, and if anybody else has a question or two they would like to ask, I will certainly call upon you. The first thing is, I think to Dr. Kroviak, I think you had some thoughts about the outdated suicide risk flag, outdated suicide risk flag policy and communications to vet centers. So if you could talk a little bit about that, I'd appreciate it.
Thank you. I wanted to comment that we have just started and issued our first 3 reviews of the vet centers, and that's an area of oversight that we have not been involved in to the level of intensity that it deserves. These centers actually diagnose and offer some form of treatment, usually in the form of individual or group counseling. There are criteria that when a veteran is recognized as having a certain level of risk for suicide, that coordination kicks in with the local VHA facility. And as you can expect, we have multiple findings toward that isn't occurring routinely. And we have shared that with VHA and RCS leadership, and many more reports to come, but that is an absolute area that requires urgent attention to ensure that that communication is 100% consistent. It is the only way to ensure that veterans get the higher level of care they need in the VHA setting, graduating from the care that can be provided at the vet center.
Very good. When the secretary was visiting my district, we went to our vet center, as I mentioned, and they certainly raised this as an issue. They also raised as an issue that when they went down to the West LA medical facility to receive their COVID shots, they were denied because they were told they were not employees. And, even though they had their badges, et cetera, the great thing about the vet center is it's sort of a standalone and doesn't have the bureaucracy of the VA, but it's certainly important that the VA recognizes the vet center as an integral part of the entire operation. So that was very disconcerting to hear that. And it seemed to me, there should be someone at a medical center that is actually responsible, for that communication and making sure that that communication happens, with the vet centers, within their region. So anyway, I'm glad to hear that you're digging into that, because I think it's critically important, and hopefully you can come up with some suggestions in terms of better management approaches to really resolve this and make sure that it's a fail-safe communication system. So thank you for that. I also wanted to ask the VA folks here, really, Ms. Oshinsky, I'll start with you, just about my staff did determine that at least 10 VHA policies related to patient safety or quality of care expired between 3 and 8 years ago, and VHA has yet to update or recertify them. And I understand that these policies remain in effect until rescinded or replaced, but I think we can all agree that healthcare is a field that evolves rapidly, and VHA should be regularly updating or at least reviewing and recertifying policies, particularly ones related to patient safety. So I guess my question is, in your experience, how long does it typically take to update VHA policy directives?
I'm going to give a quick answer because others know better than me on this. It can be a very lengthy process given what we do. But I would point out, as you said, that they are in effect even when they are past their date. So Dr. Cox, though, I think has worked a lot on this project. So I would turn to him for more insight.
Sure, great. I'm happy to address that question, Chairwoman Brownlee. First of all, the answer to the question, as Ms. Oshinsky said, is it can be a year or more, depending on the length of time for review, especially legal review and a review by our labor relations management partners. So I track all of our expired or soon to expire policies every week. I have my staff report to me every Tuesday on progress towards getting them approved, and so getting to the point where I can sign and publish them. In this calendar year, 2021, we published a new directive on state licensing board reporting, which streamlines that process, shortens the timelines for required reporting, and very clearly and directly identifies the responsible party of each medical center and each visit for overseeing that process. We also published a new credentialing directive, which I had committed to this committee, or to the Oversight and Accountability Committee, Oversight and Investigations Committee a couple of years ago. I'm happy to say that that directive made it through that whole concurrence process and was published in this calendar year. And we are poised to overhaul the entire national programs for quality and patient safety under the auspices of this new office that I lead. I think it probably bears pointing out that the Office of Quality and Patient Safety was established just about 1 year ago when the central office underwent a significant realignment. And it's telling that that office is at the assistant undersecretary level. You know, in most private healthcare systems, the quality manager, the quality department maybe reports to the chief medical officer or is a special assistant off to the side reporting to the chief executive. VHA recognized the importance of quality and patient safety is such that it established this function at the same level as the assistant undersecretaries for operations, Ms. Oshinsky, as the chief medical officer, as the chief nursing officer, and all of my colleagues. So it's on an equal par with all the members of the VHA senior leadership team. And so in the first year, we've spent our time establishing a leadership team. I've hired new executives to lead the divisions of quality management and the National Center for Patient Safety, which are part of my organization, as well as the data analytics and performance measurement branch. And now in year 2, we're poised to publish the new directive that will replace the one that was rescinded, one of those that you referred to, the enterprise framework for quality and safety, and to implement it and to create stronger alignment and better connection with the VISN quality and safety officers and VISN executive leadership, and through them all the way down to the front line. So we have big plans in place, and I look forward to telling you more about them at another time.
So you're talking about it takes, you know, a year plus, you know, to look at these policies, update these policies, and also to recertify these policies. So it takes up to a year to recertify even the policy. Because these that I'm talking about, this, you know, there's 10 that's have expired between 3 and 8 years ago. So that's well beyond a year worth of time. So I am just curious.
Well, Madam Chairwoman, if you or your staff could share that list of the 10 policies that you're referring to, we'd be happy to update you on the status of each one.
Okay, and Dr. Cox, I think, you know, you are the consistency here in terms of you've been at every one of our hearings, you know, on this topic, and we appreciate it. And I know in our hearings in 2017 and 2019, you assured the committee that the VHA was going to update its credentialing and privileging policies at the time. And you just mentioned that you just completed the credentialing policy, but we still haven't seen any updates on the privileging policy yet.
Well, I can tell you, Madam Chairwoman, that we decided to split credentialing and privileging into 2 separate shorter directives because each area is complex and slightly different. As I mentioned, the credentialing policy was published. The privileging policy, we've been done with our work on it for a number of months. It has been going through legal review. I think part of the issue in preventing our general counsel from clearing it back to VHA has to do with the fair hearing requirement for providers who are under scrutiny for potential malpractice or professional incompetence or substandard care. I think they want to make sure that the hearing procedures are in line with hearing procedures used in other settings, not just in the setting of privileging or reprivileging. So we're hopeful that we get the legal opinions back soon so that we can publish that privileging directive as well.
Well, we will look forward. We will look forward to seeing this because we deem it to be an important policy in terms of quality healthcare delivery. So, General Bergman, you have more questions?
Thanks, Madam Chairwoman. I have one. Ms. Oshinsky, VA recently announced that the department would be decommissioning the Office of Community Care and creating a new Office of Integrated Veteran Care. What, if any, impact will this have on quality and safety, given that access underlies both of these measures?
Thanks, General Bergman. I would say that one of the things that we believe is going to happen is we integrate. And so rather than saying decommissioning community care, I think what we're looking at is integrating access with community care so that one of the things that's going to happen is a far better view of the case management of those individuals as they move between VA care and community care. So honestly, that is the primary rationale for trying to do this, because in the silos that currently exist, it is sometimes becomes difficult to pass information and really kind of ensure exactly what you're asking about, which is to make sure that we're doing care as quickly as possible and that we're overseeing the quality of that care, that there's not duplicate care, that things aren't missed as people move from one to the other. So really making sure the leadership of those two areas is aligned is going to make care better, and especially quality of care. I don't know if either of the other individuals have any comments about this.
I'd like to move on, because I just got, you mentioned when you use the word silo, you know, silos on a farm, and I used to work part-time on a farm to make a little money and help the farmer, but silos are for silage. And if you leave silage in there too long, it rots, and you cannot use it for feed for the animals. So the point is, I like your reference to the silos, because we have to eliminate the silos as best we can, but where they do have to exist, we have to move the information, and the flow of information has to be appropriately rapid. Moving forward with that in mind, how will you ensure that this integration in no way impedes the access to care in the community that veterans are entitled to under the law, under the Mission Act, and that veterans will be empowered to make the best healthcare decision for them, whether they are seeking care in the VA or in the community?
We are fully committed to ensuring that we fulfill the Mission Act requirements, and that any veteran is given the capability of choosing to go into care in the community. If there are access issues, if it's in the best medical interest of the veteran. I think what happened a little bit when we first started is people were pushed there regardless if they wanted to stay at the VA. So that is one thing, but honestly, there will always be the question, the decision will be with the veteran. So we will put oversight mechanisms in place. I mean, we may see changes in where people decide to get their care, but I assure you, we will meet the Mission Act requirements. I do not anticipate that there's going to be significant changes, but what I do anticipate is that exactly what you said, information will move more readily between those organizations.
Thanks, Madam Chairwoman, and I yield back.
Thank you, General. Congressman Mervan.
Thank you, Chairwoman. I appreciate this opportunity, and I first want to use a couple of seconds. General Bergman, I want to thank you respectfully for giving that example of silos and the moving of information. I use that term all the time, and now I have a deeper knowledge, and I do appreciate that. And I mean that wholeheartedly. And with that being said, Ms. Oshinsky, I understand that the VHA established an Office of Internal Audit several years ago. What internal audits did VHA conduct in fiscal year 2018 through fiscal year 2020? And what overall lessons did VHA learn in the process of conducting them?
So in order to be complete, Congressman, I'm going to need to submit some of that information for the record. But I can tell you that I am on the oversight board for the compliance and internal review. So one of the things I can tell you that we looked at is timeliness of mammograms, follow up to those items. I think there are some, I'm trying to recall a few of the others. There may have been issues related to access to make sure that we're doing the right things. What happens when we go through the beginning of the year is the oversight board looks at what are some of the highest risk areas that we think that we have in our organization. And this comes from people in the field as well as in headquarters, looking at where we see gaps. We then come to an agreement about what are some of the highest risk areas that we want to look at with internal controls. And I would say that I talked with Dr. Tracy Davis Bradley the other day, who runs that organization and who is very involved in the GAO work that we're doing to make sure that we have things in place to implement policies and to oversee that. So let me get you that list, but that's an example of some of the things that we've done. And then we make sure that those suggestions are implemented and take those lessons to other things that we do in the future. But I'd be pleased to share those with you.
And I thank you very much. And just to recap, you will get us the highest 5 ranking the highest 5 ranked risks that were identified by the office, correct?
Yes.
Okay. And how did VHA come to the conclusion that these were the highest risk issues?
Well, one of the things, and again, I won't say that they are necessarily the 5 highest risks. We have an oversight board who looks at a whole variety of things. That is the agreement of the oversight board of things, and also looking at things that can be accomplished in a period of time. And so some of them may be much more labor intensive, others may be less, but we're constantly looking at what are the things that need additional oversight.
Thank you very much. With that, Lady Chairman, I yield back my time.
Thank you, Congressman. I was told that Representative Radewagen might have additional questions. I do not see her on the screen. So going once, going twice, I don't see her. So General Bergman, I think we've come to a conclusion. Do you have any closing comments?
Yes, Madam Chairwoman, I do, very briefly. You know, I think I'd use the acronym BLUF, B-L-U-F, bottom line up front. Well, this is bottom line up front at the end of the hearing. But it's time for the Biden administration to really, really, really step up to enable Secretary McDonough to lead and execute his vision of a proactive, responsible, and accountable VA. Any leader being put in a secretary position must be properly resourced and backed up by the higher headquarters, in this case, the White House. To repeat, it's time for the Biden administration to finally begin to exhibit a true sense of urgency that we've talked about it over the years in VA committee hearings with regard to all veterans issues, but especially physical and mental health. And with that, thank you to all the witnesses for your honest testimony, and thanks, Madam Chairwoman, for an extra special positive hearing.
Thank you, General Bergman, for that. And, you know, I think to be fair, this issue has crossed over many administrations. While I want to say right up front that, you know, in most cases, VA gives the highest of quality healthcare to our veterans, and that should be acknowledged. But we need to have an enterprise that operates under one directive and has that oversight and accountability so that we can ensure that we have patient safety and the highest quality of care. And Ms. Oshinsky, thank you again. You know, we really appreciate you being here, but most importantly, we appreciate 41 years of service to our nation's veterans, to our nation. So we are very, very grateful for that. And I certainly hope that the VA has enough smarts to replace a high quality individual like you in your job so that we can proceed with this. The Secretary knows that I'm unrelenting on this issue, and we will continue to do, this committee will continue to do its oversight responsibilities to ensure that the VA and the GAO and the OIG and our veterans are all working in a collaborative way to always put the VA in an continuous improvement model. So we can always be better. And I do hope you know, that what the IOG provides for us, what the GAO provides for us, I hope our leaders at the highest level are receiving these reports and reading these reports, because I think while these reports might point out some shortcomings, it's valuable information that can be incorporated into a culture of continuous improvement around quality care and patient safety. And most importantly, I think it provides the ability to provide a culture of safety for everybody to be an honest and humble team player, that everyone has the comfort level to express concerns or to report something that they see within the organization that is not right. All of that just helps us to improve. And that's what we all want to do. So I thank you all for being here. Thank you for your testimony. Thank you for your work to get us into an even better place. And as I said, this committee will be unrelenting to ensure that we ultimately get there. And so with that, without objection, this concludes today's hearing. All members will have 5 legislative days to revise and extend their remarks and include extraneous materials. And with that, I will adjourn this meeting. Thank you.